macular hole repair without gas tamponade. I have no financial disclosure. With RM peeling, the closure rates of macular holes after primary surgery have exceeded 95%. Currently, the inverted RM flap technique has become a commonly used and effective method for repairing macular holes. However, electron microscopy has shown us the RM's vitreous and retinal size are quite different, which is crucial for our surgical strategies. Additionally, all macular holes close and the time frame for their closure have always been topics of great interest. Previously, the dynamics of macular hole closure in gas tamponade eyes within 24 hours of surgery using SSOCT was studied, focusing on the dynamic process of early post-operative macular hole closure. However, the presence of gas tamponade introduced certain limitations to the observations, making it difficult to fully capture the complete closure dynamics. Here, we introduce a novel RM flap technique, non-inverted RM free flap technique, used alongside Professor Li's innovative spot technique. This technique keeps the RM free flap stable, so we believe macular hole can close well without gas tamponade, allowing real-time observation of the closure process. We collected 10 cases. All patients advanced this technique and without a gas tamponade. Our results showed that the earliest closure time was 20 minutes after surgery. It's important to note that the timing started from when the RM covered the macular hole. Let's see one case. This case was a 58-year-old female who had macular hole in her right eye. And we can see that the RM was grasped around the macular hole with an RM forceps at first. And then period of a healthy RM free flap assisted by support technique. Shift the flap to cover the macular hole, then massage of the rim of the flap. Inject dispersive OVD along the rim of the flap. First, remove the PFCL. Then, close the 3 ports. We also applied for OCT to evaluate the closure of macular hole intraoperatively. Nearly closed. The second case was a 58-year-old female who had macular hole. Staining the RM by ICG. And we advanced the same method to close the macular hole. Here, the unhealthy RM. The arm in this area is healthy. So we made a flap. Flap have two pedicle. So when you resting the flap, you peel the flap, you can see the two pedicle. Then inject the PFCL to flatten the flap. Top of the pedicle. Then shift the free flap to cover the macular hole. Adjust the flap. Inject OVD along the rim of the flap. Remove the PFCL completely. Then close the 3 ports. After surgery, we followed up with the patients at 20 minutes, 2 hours, 4 hours, 8 hours, 24 hours, 48 hours, and at the time of closure. We noticed something interesting. While the macular hole seemed to close during the surgery, it sometimes reopened afterward. We think this might be due to things like incomplete adhesion, changes in head position, or retinal displacement. In summary, this innovative macular hole repair technique utilizing a single layer IM scaffold to provide a flat, stable, and non-displaceable cover. It preserves the retinal layer structure, promotes effective repair, and minimizes gliosis with no gas tamponade required. It removes the requirement for face-down position, reduces the risk of cataracts, and allows for air travel post-surgery. This approach ensures both surgical efficiency and patient comfort. Thank you for all your attention. See you next time.